with the advent of US-based Intuitive Surgical's Da Vinci robot, which has since familiarized clinicians and consumers with the idea and practice of robot-assisted surgery. And today, a host of established medtech giants and newer, more specialized companies are working to bring their own offerings to this multi-billion-dollar market for general surgery, orthopedic surgery, and other applications. And we can't talk about the robotic surgery market in 2020 without talking about CMR Surgical, the creator of the Versius robot for minimal access surgery. Despite only being founded about 6 or 7 years ago now, the UK-grown company has attracted the backing of investors and health systems. CMR closed a $240 million Series C round last year, which it claimed as the largest ever private medtech raise in Europe. Counts GE Healthcare among its big name supporters. Those funds are instrumental as even amid the pandemic, CMR is rolling out its Versius robot in Europe, launching for the first time in France just this past week. So here today to share firsthand about the story of CMR, the current state of robotic surgery, and the future of tech in the operating room is CMR's own Dr. Mark Slack, who for many years was a consultant gynecological surgeon at Cambridge University Hospitals and is a co-founder of the company and serves as its chief medical officer. So Mark, thanks for being here today to tell us more.
All right, thanks for having me. I'm delighted to be here.
So first off, would love if you could give us an inside look at the arc of the last 6 or 7 years. How did a company like CMR beat some longer standing medtech companies to this commercialization phase, and what does Versius bring to the market that's new and different?
Well, it's a synergy of behavior. I've done quite a lot of medtech innovation in the past, in different round the corner of my own profession. Cambridge, as you probably know, is quite a hub for medtech development and does a lot of medtech development for many international companies around the world. And then gives it back to them to sell on. I got together with my four co-founders, now friends, and they were working on the concept of robotics, and they felt that they could build a better robot than they had seen on offer. I, at the same time, had been a minimal access surgeon for some years, and I was concerned that I had real difficulty teaching minimal access surgery to all the people that wanted to do it. I ran the minimal access training program for OBGYN in Cambridge and realized that some people just couldn't master the technical skills required to do the complex surgery. So I was looking for something that maybe could overcome that. And so we started a conversation about, could we build a robot that could overcome these limitations? So we went back out to the medical profession and said, what would you want if you had a surgical robot? Because at that stage, even though robots have been around for 20 years, their penetration of the market is only around about 5 to 7%, of minimal access. So clearly something was holding it back. And anyway, the community came back and said they wanted an affordable robot, a much smaller one that was portable, one that wouldn't dominate theater, could be used in multiple theaters, easily to learn to work on, and etc. And of course, such a thing didn't exist. So we just literally set out to build our own. And so the five of us sat down, started doing planning, made a small raise, which enabled people to leave their day jobs and start building the robot. And then, of course, things just accelerated, and here we are. So we have assembled a dream team of technical specialists. We have physicists, mathematicians. We have some pretty bright medics floating around as well, and all the time we've stuck to the basics. What is it we're trying to achieve? I.e., better healthcare for people, to be responsible within the healthcare sector, so evidence, proper research, etc. And somehow we seem to have pulled it off.
And so you mentioned that one of the tenets of Versius is trying to be a more affordable option, particularly as you're launching this product during a year when we have a pandemic. and hospitals are facing constraints from trying to treat COVID-19 patients. How have you made your value pitch this year?
Well, we've always we've tried to make the machinery itself more affordable. We've lowered the price cost. We have a couple of models. So the one is people can buy it as capital upfront cost, and the alternative one is, which we in many cases prefer, is that they buy a managed care option, almost lease it. So they get the system. They and I, we agree the number of cases they're going to do per annum. We work at a price and we go forward. Our actual target of cost is, conventional laparoscopic straight stick surgery. Because actually, to get the people to adopt us, that's who we are competing with. I'm not here to compete with another robot. I'm actually here more to compete with straight stick surgery and provide surgeons with a better option than, straight stick with all the limitations that rigid, non-articulated instruments have. So, and also, of course, being able to use it in multiple theaters, we hope to increase the use of the robots in a theater. The worst thing a robot can do is stand around not working. That's just a complete waste of time. So if I was operating in my theater, finished a case, and my next case was non-robotic, it can easily be wheeled next door into the next theater and set up in double quick time. I mean, we take it from the laboratory to my headquarters in the back of a truck regularly. We move it across the city. This is a genuinely portable robot. You can see behind me the what we call bedside units. They're 38 by 38 centimeters in size, and each one carries an instrument. They fold up quite nicely, press a button, they make a sweet sound, and they fold themselves down. And then we can put them in a carrying case and move them. So very, very movable and affordable. And so increasing use also makes them more affordable. So we want to, the worst thing a robot can do is sit around doing nothing. That's a waste of money.
So you talked about leasing. That still is a relatively new phenomenon within robotic surgery. Do you see that being the future of how hospitals acquire these systems? And what does that mean for potential future models of the Perseus robot?
I think that depends on the hospital themselves. There are certainly hospitals and there are certainly health economies where people would prefer to pay cash and do an upfront cash payment and move on. The leasing is quite a good one because it also puts us in a position to replenish and replace more easily. I mean, robotics is a fast-moving world, and the robot you build today is going to be quite different from the one in 24 months' time. And we want to be able to accommodate those changes, both software and hardware. So I see that as one of the ways around it. But we certainly still have purchasers who want to buy it up front and own it in its entirety, and that's available as well.
So now that the market is more mature, you have the benefit of clinicians and consumers being more familiar with this technology, but also how has that perhaps changed the bar when it comes to the clinical evidence that payers want to see when deciding whether or not to make this investment?
Yeah, I think as a company, we're completely with that. So I'm, an old-time subscriber to evidence-based medicine. I've spent most of my career at Cambridge University, which is a large teaching hospital here in the UK, or teaching university. And one of the things we're awfully proud of is our research record. So right from the beginning of this program, we've underpinned it with a research strategy. So I have loosely modeled my strategy to a thing called the ideal collaboration. An ideal is a collaboration, international collaboration of researchers, which stands for idea, development, exploration, assessment, and long-term outcome. And it's to try and put a frame around how you do this. So to give you an idea of what we've done, we built the robot, through its various types until we got to a point that we had something usable. We wrote a paper on the robot itself. We then started using it in cadaveric studies. And we've done over 300 cadaver studies to make sure that we could do our port placements correctly, that we could get the reach we needed, that we could do the operations we were doing. And we worked with multiple clinical teams all around the world to achieve this as well. And all of those we've written up as well. So we've written up our general surgery ones, the gynae ones. We then moved on to porcine studies, so we could look at safety and instrumentation. Those have also been included in the early write-ups. And then finally, using the ideal, we moved into human studies. So by the time we got to our first human study, I was completely confident about the abilities of the robot. I knew of the system, Versailles. I knew what it could reach, what it couldn't. I knew what its strengths were and what its weaknesses were. We knew our port placements perfectly. And of course, we had trained our surgeons on our training program, so they were also proficient already. When we then started, like Ideal recommends, small clinical study, um, simple cases, and looked at the outcomes. And after 30, we analyzed those and put those into publication. And then we progressed to the next phase of Ideal, which is to do a large cohort study. And we did two very large cohort studies in triple figures with appropriate follow-up in different surgical types. And then the final part of this evidence based approach to introduction of a new system, we have a registry. So every single patient that we operate on goes into our registry. So at the same time that we're doing studies, we're collecting real world data, which will hopefully give us real world evidence. So, even though we're such a young company and we've had a 6-month hiatus due to COVID, we've got over 800 patients on our database already, which are currently being analyzed for publication. So I think I've had about 14 publications already this year on Versius, so that we stick to an evidence-based framework and a mature and responsible method of introduction.
So, as you said, you are rolling out this product during the year of COVID-19. So, as healthcare providers are understandably devoting time to that, how are you connecting with them, elevating the brand, training clinicians during this time when so many elective procedures haven't been happening?
Well, I mean, that's another whole subject. One of the real fears about COVID is that people are going to be denied their routine health care, and that we may see excess deaths as a consequence of COVID for people not getting the health care that they deserve. The nice thing about our system is that it's small. So in most of our hospitals, we stood it down in the beginning of the pandemic. But then as the hospital started opening up again, we were able to bring it out. We were able to, in some teams, remotely retrain them to make sure they were familiar with the function of the system, and then have gradually introduced it back into our hospitals. So all our hospitals in the UK are now up and running. All my hospitals in India are up and running. And not only have we reinvigorated the hospitals in Europe, but we have made new sales and started in new hospitals in Europe. I mean, there are obvious benefits to a robotic system in COVID. Less people around the table, surgeons sitting at a greater distance. We haven't studied it formally, but yes, it certainly reduces. If you're doing robotic minimal access surgery, you normally have to have somebody holding the camera. Well, we don't. The robot holds the camera and the surgeon controls it from the console. So that's one person less already. We only need one scrub at the bedside. They can stand back from the table for quite a large part of the operation. We can use people to do manipulation of vaginal instruments. So I do, and I'm doing some work with an academic group at the National Institute of Health Research, looking at the possible benefits of robotics in a COVID environment. But that's quite early work. So yeah, I'm delighted to say we are back working, and of course, patients getting the benefit. The worst thing you could do to a patient is deny them minimal access surgery because of COVID, and then they get the far higher complication rate you get with open surgery than you would with minimal access. So we've been very keen to get back to full working.
Mark, I'd like to hear more about the customers that you've gained so far and those that you're targeting in terms of their approach to tech in the OR. So it's a little bit of a chicken or the egg question. Are you finding that when they acquire Versius, that's part of a push to get more new technology in the OR, or have you found these customers to be early adopters of a lot of the different types of technology that are growing now?
Look, they are always innovators, and there's always 2% of the medical profession that want every new toy on the block. And I'm not going to criticize them because I suspect I'm probably one of them. And so much so that I've even built my own when I didn't have a new one to go to. But yeah, we've had the innovators that are vitally interested in working with us, and they've proved incredible partners to work with because these are people that are used to working with new tech. But we've also had um, absolutely jobbing surgeons who are very good surgeons doing an excellent job in both teaching and non-teaching hospitals who we've engaged with. So in the UK, two of my hospitals are what we call district general hospitals. So these are non-teaching hospitals just providing really good service to the community. And we've got them in two teaching hospitals, one of which is one of the biggest in Europe. And they obviously are doing it both from the clinical perspective, but they're also they're doing studies around it and so on. So I see us at a sort of tipping point with robotics. Robotics has been sitting around about 7% of minimal access surgery, and I think we're getting up to 8, 9%. And once you get to that level, on a thing called the diffusion of innovation, a curve, by a economist called Everett Rogers, we would be at, I think, about the tipping point. And what I find now at meetings, phone calls, emails I get from people, there's a huge number of surgeons that seem to have decided in their minds that the way forward is robotic surgery, which we do as well. I mean, minimal access surgery has been around for 30 years, and still only 30 to 40% of surgeries in the United States, for example, are done minimal access. And the reason more aren't being done is it's difficult. And so I'm hoping that the advent of the robot with its better visualization, the articulated instruments, the better hand movements, enables more surgeons to bridge that technical difficulty and therefore more patients to get minimal access surgery with all the benefits that they get with it.
I think people always have questions about robots replacing human jobs. In the case of Versius, I know, it doesn't take the surgeon out of the picture, but are there job functions that this does take out of a surgical team?
No, it reduces the number of people you need in a theater, and I think that's a good thing. Internationally, if you go beyond the first world countries, you go to low and middle income countries, they have a real difficulty having enough healthcare professionals to do the work that is actually needed to provide good healthcare in those countries. So one of the worst things you can have is while I'm doing a 2-hour minimal access keyhole surgery, to have another doctor standing holding a camera passively, not really contributing. Now that's fine if it's in a teaching institution, but it's not so good if you're in a district general hospital or a hospital that's providing a service hospital, because then you're actually taking a person who could be doing something more meaningful away and standing there next to your table as a passive camera holder. So that's a great example. And in fact, as a surgeon, believe me, it's way better me controlling the camera than a bored senior house officer holding on to it and not putting it where I want it to be. So those are real benefits that I see already in the short term that we've done.
So in this initial stage of commercialization, we're seeing Versius in the UK, now in France. You've talked about Australia, New Zealand, Asia. When will we see Versius in the US? And there's a lot of established names in the US, be it Intuitive, Johnson & Johnson, Medtronic, trying to come to market. How do you introduce yourself to these US customers and vie for a place in this more saturated market?
Well, we would be brain dead if we didn't want to go into the US. The US is the robotic market of the world, and the vast majority of robotic procedures are done in the US, and the vast majority of robotic development is done in the US. So I have very close collaboration with a lot of US surgeons as we work towards getting ready for the US. And so we are working on FDA, and
Não?
we aim to have a product in the US in the not
Só
too
para
distant
ficar com
future.
ela ou em pezinha?
You are absolutely right. The opposition in the US is pretty daunting. Companies like Johnson & Johnson and Medtronic are not exactly small. And I was doing a talk earlier today. People ask me all the time, how can we cope against them? And you know, I always have to say, well, I look at our track record in Cambridge and, you know, what have we done in the past? And, you know, amongst other things, we discovered the electron, the neutron, nuclear fission, the jet engine, IVF. So we've done okay in the past. We think we can do okay in the future. You know, we put together a fabulous company. We've got some of the brightest brains around here, and we stick into principles, which is to put the patient slap bang in the center of what we're trying to do and achieve. And so we are very motivated to produce something good. The other point as well is that the minimal access market is mammoth. You know, Intuitive have built a fabulous company out of 5% share of minimal access. Is another 95% of minimal access surgery to address. And then you've got all the open surgery as well. So I think there's plenty of room for all of us. And I don't think we need to get into an arms race. I think we all need to concentrate and do good research, publishing good outcomes, and producing something that will benefit the patients and the health community in the long run.
All right, Mark, I'd love to play a little round of underrated or overrated with you. So I'm going to get right into that. Telesurgery, underrated or overrated?
Well, you see, at the moment, I've got to say underrated because I just published a paper on telesurgery 2 days ago. So clearly something I have an interest in. I think telesurgery, in terms of the surgeon being in New York and the patient being in Strasbourg, at the moment, with the current technical limitations, impossible. However, there are other areas, and COVID has raised this teleproctoring. So we've been doing a lot of work now and we've actually already practiced this, where the surgeon is proctored by another surgeon who might be in another country. So that brings an efficiency into teaching. So underrated.
Right. What about robots used to replace certain nursing functions, like taking vital signs?
Yeah, I think that, again, has got to be something that I think underrated at the moment. And I think I can see something great there. We have an international shortage of nurses. And it's one thing in the first world countries to look at it, but go to the low and middle income countries and see the shortages that they have there. And I think robots doing a whole range of functions, even from just communicating with patients, is potentially a good thing. And I see that area accelerating, both socially, to give companions to elderly, and to do basic functions, both in theatre and so on. And it won't be replacing the nurses, it will be taking the menial tasks away from the nurses so that they can provide a more professional function for the patients that need them.
All right, last one, working from home, underrated or overrated?
Oh, that's a mixture. So at 6:30 in the morning, when I don't have to get in my car and do a commute, hugely underrated. Love it. You know, being able to nip out quickly and get a cup of tea in between chatting, underrated. Missing the environment around the people that I normally work with, massively overrated. I think we humans need to interact. I need to speak to people. I need to bounce ideas off people. Sort of the being on the television the whole time, I think we just lack something, we miss something. Giving talks, I love being live. I love interacting with my audience. I love feeling that they're in the room with me. So in that case, overrated. But in terms of efficiency, I normally travel twice a month internationally. My family think the fact that I can do mostly on the computer. So it's a mix. I don't know.
All right, and lastly, Dr. Slack, what can't robotic yet, and how is that at all shaping what the next 12 months looks like at CMRC?
You mean in which types of surgery? So I think we've done all the soft tissue, so all the abdominal surgery, certainly all the chest surgery you can do. You know, I think people are the orthopedic robots are brilliant. They're doing a lot. Head transplanting, that's a fantastic robot as well. I think we'll go into the brain in much more. What the robot can't do at the moment is autonomous function. And what it needs is a surgeon to drive it, a surgeon to make sure it's doing the right thing. And that is the main function that it can't do.
Well, Dr. Mark Slack, thanks again for the conversation, and thanks to everyone.